Okay, so because I don't have it in my notes, that's why I want to talk about this first quickly before I get into the diseases. Like I definitely think it'd be good to talk about, hey, what goes on with the ventilator associated pneumonia? What are the high alarm and low alarm means? Like those are things that we could see in our NCLEX, and I've been doing NCLEX prep, and a lot of that stuff has been coming up. So I definitely think it would be good. So there's two different things that I want to talk about with respiratory medications that's been really helping me teach it to the juniors is there's medication types for respiratory diseases or disorders like asthma and COPD are the most common ones. And even when we're talking about the respiratory medications, we're mainly talking about those. And so the relievers are the medications that we use for exercise induced or asthma attacks. In other words, emergency related issues when it comes to respiratory. So we typically give a short acting beta 2 or anticholinergic drugs like ipratropium. I spelled terribly, so if it's wrong, it's okay. An example of a short acting, oh no, where'd it go? Um, okay, so I don't know what I did, but I removed the text box. But an example of a short acting beta 2 is albuterol. So can anyone tell me, I can't spell, but can anyone tell me why we might want to use a short acting versus a long acting when it comes to a patient if they have an asthma attack?
Short acting is more for acute cases, while long acting is more for, I guess, chronic cases.
Yes, right. But also imagine this, right? If you're having an asthma attack or an exercise-induced asthma, right? And you need something to work immediately. Long actings, as you said, maintenance. That's a really important word for chronic long term. So if I'm going to give something that's going to work in a couple of hours because it's a maintenance drug, that's not going to help my patient who's having immediate bronchospasms and needs immediate attention. So that's where we start to see why we want a short acting like albuterol versus a long acting like salmeterol or formoterol. Um, Anticholinergics, which, if we remember, Dr. Radowski always said SLUD, SLUDD. Does anybody remember what that means?
It was an acronym for side effects.
Yes, and what the cholinergic class does, because cholinergic works on that parasympathetic system. So, what sorts of um, well, what does SLUD mean then in terms of being parasympathetic acting?
Salivation, urination. I don't remember the L, but
Okay.
things like that. Digestion.
Mm-hmm.
Um, yeah, I'm blanking out on the other two.
No, that's totally okay. Um, no, yeah, those are definitely it. It's SLUD, right? So S, salvation, L, lacrimation, U, urination, D, digestion, the other D, defecation. So SLUD means those are the symptoms that we're going to get with a cholinergic acting drug. But this is anticholinergic. That's why it's so perfect as a reliever drug because it reduces secretions. And parasympathetic normally causes bronchospasms. But if we have anticholinergic or we're blocking those receptors, we're going to have bronchodilation and we're going to have reduced secretions, which is going to help our asthmatics, our COPDs, our bronchitis patients, and all of that. But we usually give drugs like ipratropium or tiotropium to patients if short acting beta 2s aren't as effective, but those are our reliever drugs, those two. Now, does anybody remember a side effect of albuterol or those beta 2 acting drugs that we really need to pay attention for?
I think it was hypotension.
Which one? What did you? I couldn't hear that.
Hypotension.
Hypo?
Mm, I could be wrong.
I mean, we have that in the beta blockers, but this acts on those beta 2 receptors. So they encourage these beta 2s. So that means it stimulates the sympathetic system. So what sorts of symptoms do we expect?
I guess in that case, sympathetic increased heart rate.
Yes, tachycardia and tremors are the two that you will see, or the main symptom that you will see as being asked on your test. So, that's one. Another one is tremors, as I said, hypertension instead of hypo, because these act on those beta 2s. And even though it acts on beta 2, because it's sympathetic, it could always slightly stimulate a beta 1. But I emphasize, even when I'm going to study for the NCLEX, is remembering what those receptors do, because they tell you a lot about the drug. So since I know this is a sympathetic acting drug and it doesn't block those receptors, but it agonizes them or mimics them, I expect increased heart rate, increased blood pressure, things like that. An anticholinergic is anti-SLUD. So if you know that mnemonic, then you know, okay, I know what this drug class does. And what's really good about this is that when you understand it like that, I think it makes understanding the symptoms, the side effects much easier, in my experience. And then you also know what happens when you have those beta blockers, because you're going to have the opposite. Or when you have cholinergic drugs, you're going to have the opposite, right? Like atropine is an anticholinergic, but something like buchanan is like, I think that's one of them, I'm not sure. But I think that's one of them, that's a cholinergic acting drug. So when you know that and you're able to recognize that, it makes it easier. Now we have controllers like long-acting beta 2s. So why would we give a long-acting beta 2 to a patient who has chronic asthma or COPD? Well, as I was mentioning before, long-acting does not work like those short-acting bronchodilators, or like those anticholinergics, right? So when we want a maintenance drug for respiratory, we want something that's going to work long-term, that's going to help with control, and isn't going to cause any sort of immediate bronchodilation, because we don't need that. This is for long-term maintenance, right? And we always give a bronchodilator first, then a steroid. And this is because the bronchodilators still act more quickly than a steroid would. But when you give the bronchodilator first and then the steroid, once the steroid starts to kick into the system, it actually makes the beta 2 receptors more increased or mimicked in symptoms. So it actually further helps that bronchodilation. And steroids also help with inflammation. And remember, all of these beta acting drugs, they affect our diabetic patients and they mask the symptoms of hypoglycemia. So we really have to, whether it's beta blockers or beta agonists like these albuterol and salmeterol, we really, really want to make sure that we watch out for those diabetic patients. Does anybody else remember some very important patient in teaching when we give a steroid like prednisone or things like that?
Diabetic patients.
Why?
It induces hyperglycemia.
Yes. So another drug that we have to watch out for those diabetic patients. What else about steroids do we need to know or teach our patient, especially if it's like an inhaled and they're taking it through the mouth?
They
They
have
have
to
to
rinse their mouth.
Why? Why do they have to rinse their mouth?
I think it could cause tooth decay, like dental issues if
A
they don't.
brush?
mucosal erosion.
It causes thrush. It causes a fungal infection. Yes, because steroids decrease your immune system response, and one of the common things that you can get is a fungal infection. So you want to tell them to rinse or gargle the mouth really thoroughly after they take that steroid. And like we said, for those diabetic patients, we really want to monitor their blood sugar levels closely because they're not going to know when they have episodes of hypoglycemia. Now, you might not remember these classes of drugs, and that's okay, but theophylline is something called a methyl-hexane or something. But a caffeine is also in that class. It's a maintenance drug because it doesn't really work that quickly, but we don't really use it much anymore because it has a really narrow therapeutic range. So it's kind of like the Joxin, where if you don't monitor those those blood levels really closely, they might have toxicity. Now, Montelukast are leukotriene inhibitors, which is basically a drug that reduces inflammation, because steroids also reduce inflammation, but this is one of those drugs that works on one of those receptors that also cause inflammation, the leukotrienes. So they help reduce inflammation, but some things that we just have to be careful with these is they all end in Lucast, so that's how you can recognize these drugs. They're also a part of these like controller drugs, and you just want to watch out for the liver because these drugs can affect the liver. They can also affect not this particular one, but some Lucast ending one that starts with Z can also affect like their warfarin levels and things like that. So you just have to be really careful with these drugs. But the main point is that those short actings, beta 2s, we give them in emergencies. That's our drug of choice when we have an exercise-induced or an asthma attack. And those long-acting beta 2s, we give for maintenance, for long-term maintenance. And if we're going to give a steroid, we must give the long-acting beta 2 first, or the bronchodilator, then the steroid. That's definitely going, probably we'll see that somewhere on our NCLEX, if not in MedSurg again. And yeah, any questions with these drugs?
I wanted to ask, could you just repeat again why you would use like one over the other, like short-acting beta 2 as opposed to the anticholinergic?
Okay, so if someone is not like as responsive to the bronchodilators, like it's not really working well with them, or let's just say this patient has a history of like heart disease or heart failure, like something very severe, since these work on the sympathetic system, these may not be very good for those patients. Or if they can't tolerate betas, like with the increased tachycardia, it's becoming so bad, we might want to give them an anticholinergic, but they both will cause that very quick response to an exercise-induced attack or an asthma attack. So you can use either of them, but just the bronchodilators are the drug of choice. But you usually give the anticholinergics if they aren't as responsive to the beta 2s, or sometimes doctors might prescribe them together because the anticholinergic can help with those secretions and aiding in the bronchodilation. I hope that answers the question.
Yeah, thank you. Oh, and earlier you said I missed what did you say caused bronchospasms? I think when you were mentioning the anticholinergics.
Oh, yeah. So cholinergic drugs, right? Because they work on parasympathetic, since it's at rest and digest, they cause bronchoconstriction or bronchospasms. So the
Oh,
anticholinergics are great because they block the parasympathetic response in the lungs. So instead of causing parasympathetic bronchospasms, they more mimic that sympathetic system and they cause bronchodilation. That's also why it's good, because parasympathetic normally causes SLUD or those secretion buildup, but now we're giving them this medication and it's anticholinergic, so it prevents secretions.
got it. Thank you so much.
You're welcome. But like I said, I don't have these drugs in my thing. I just thought this is a good summary of the main points. Like I said, there's decongestants, there's all of those. I mean, the only thing with the decongestant, they are like, I'll just write it out here so you could see it, like phenelzine or pseudoephedrine. And that's because they work on those alpha-1. So since they work on alpha-1 receptors, that vasoconstriction actually helps with the decongestion and it helps alleviate it. So that's why Phenelzine or pseudoephedrine, they're in your common cold medications because they help with decongestion. Like there's like, the antitussives like codeine and dextromorphine, but they're not as relevant to see on the NCLEX as these types of questions. Because at the end of the day, the NCLEX is testing our safety, right? Are we safe? Do we know what to do if somebody comes in, even if they're not coming into the ER, if they usually use the ER, but if they're on the med surg floor or any floor, and all of a sudden they have an asthma attack and there's a bunch of different orders, right? We need to know which one we want to give first. And we should know, okay, I want to give my bronchodilator, but if that's not there, I want to give my anticholinergic like ipratropium. Okay, so is there any questions with the drugs, or do you want to get into like the med surg part? Okay. I think we could start with med surg now. I think I'm getting good with this. Okay, now I'm sharing you could see my notes.
Yes.
Yeah.
Perfect. Okay. All right. I've been playing around with this, so I'm not very good at it. But okay, so now we've talked
Do you
about
mind putting it back in black and white? I mean, in the white background instead of the black? If not, that's okay.
Sure. Did that work?
Yes, perfect.
Okay.
Thank you so much.
Sorry, I'm not the best with technology, so when you said that, I'm like, I hope I know where that is. I think I have it do it automatically because I think it helps with the eyes. I don't know, but this might be easier to read.
Yeah, but if
but
whatever works best for you is okay for me, because I don't want you to force your eye.
oh,
So
thank
it's
you.
okay.
I'm good. I always actually get scared when it changes. I think the screen's going off or something. So thankfully
Okay.
it's not the case. But yeah, so I figured respiratory, there's not that many disorders. It's like 2 pages, so it's definitely not a lot. And I thought it would be good because out of all of it, we have ABCs, airway, breathing, circulation. So this is one of the more important systems than any, right? Because you need to breathe in order to have anything else in your body work. So I definitely think it's good to talk about all of the respiratory disorders. Okay. So one of them is pneumonia, which is like one of the leading causes of death, especially in the older population. And does anybody remember any sorts of symptoms you might get from pneumonia? Because it could be caused, right, like bacterial or viral, but like what kind of symptoms might we see with a patient who has pneumonia?
Like yellow phlegm or like green phlegm. Mucus,
Okay.
that's a sign
Yeah.
of bacteria in the lungs.
Okay.
Fever,
That right, infection.
mhm, chills.
Exactly. Yeah. All of those things, right? And it's respiratory. So dyspnea, right? Something to do with respiratory. Even if I can't remember things, I know pneumonia is a respiratory related disorder. So I expect to see some sort of respiratory complication. And they could potentially have like, you know, colored sputum. But regardless, I never really see them asking so many, symptoms of respiratory disorders because they're respiratory. You expect similar things. Things start to differ with pneumonia if it's like viral or bacterial cause because they can induce, as you said, fever and chills. So, what are some interventions for my patient if I know they have a respiratory like disorder?
Elevate the head of the bed.
Promotes oxygenation and helping with breathing. What else?
Chest PT.
Helps get rid of some of those secretions. What else? Would I give them oxygen?
Yeah.
Right? Maybe suction.
Also, we could encourage deep breathing to use the spirometer.
Yes, right? To help with that breathing. What else could we do? Right? Yeah,
Get
all of that
humi-
stuff.
Humidifier. Use
Mm-hmm.
humidifier um, to help them breathe.
Right? Yeah, we want to help with getting rid of some of those secretion. Exactly. All of the things you said, these are respiratory, and I'll be honest with you, what I'm noticing when I'm going through every system is these interventions that we're talking about, that elevating the head of the bed 30 to 45 degrees, suctioning, chest PT, deep breathing, incentive spirometer, oxygen, are just going to repeat. The only difference is maybe when, if this is bacterial pneumonia, we expect to give an antibiotic. But if it's viral, not really, right? And if they're on an antibiotic, we want to tell them, hey, make sure you continue taking that antibiotic, because if you don't, you could have complications of reinfection. Also, as Habib always emphasized, assessing their readiness to learn or wanting to learn on how to use the incentive spirometer, right? Assessing their ability to want to know interventions that are going to help them is important, because we could tell them all they want, but if they don't care, then there might not be a necessity to teach them all of this if they don't really want to hear it. And as you said, give them like humidifier, loosen secretions. All of this we're going to see repeated again. So now we have ventilator-associated pneumonia. So we have things like dyspnea, fever, cough, right? But they're on a ventilator, so it's going to be a little harder to do certain things. But what sorts of interventions, thinking about all the respiratory interventions we said before, would we want to do for this type of patient? We could elevate the head of the bed because it's respiratory. It's still going to promote oxygenation and breathing. What else could we do?
Rinse their mouth with chlorhexidine.
To prevent any sort of infection that they might get that seeps into their airway from the ventilators. What else can we do?
Suction their trach as needed.
Yeah, right. If there's some sort of secretion buildup, we could suction. Can we do chest PT?
Yes.
Yeah, it's not going to hurt them. It would help loosen secretions. And I remember this term sedation vacations, where they try to take them off some of that sedation to see if they're able to breathe on their own, to try to extubate them, because we don't want them on a ventilator forever because they might get long-term complications. So we want to try to reduce the need for the use of the ventilator. But I think something that was mentioned that was really important is all, like I said, hell of the bed elevated, suctioning, chest PT, all of this stuff comes back. The thing that's unique about the ventilator-associated pneumonia is the oral care with the chlorhexidine. That's a little different than all the other ones, but all the other like sorts of interventions that you would do are the exact same. So with that being said, we could also have something related to aspiration. Now, what sort of aspiration precautions should we do with our patient?
Still, we elevate the head of the bed.
Okay.
When we feed in, we like bite size. Is it bite size? Like we make sure that they're in certain size, so because we don't want them to choke.
Okay.
Continuously suctioning them to avoid aspiration.
Yes. What about if we want to do chest PT on a patient, right? And they have an NG tube. What should we do?
Hold the feet.
Because they can choke. And how do we check the placement?
You gotta make sure you hear the whooshing sound when you put in air.
Is there any others? We could do a chest x-ray to assess if they have that.
Yes.
Trying to think if there's I know chest x-ray, the air.
Sorry, I didn't know we were still talking about a patient that was on on the feeding tube. That's why I said As I was saying, bite size. I'm sorry.
No, I mean, even they might not have an NG2, but even with aspiration precautions, you want to do smaller
Okay.
food, especially if they're at risk for choking.
Okay.
What about so like I said, we want to hold if we're doing any sort of chest PT, or if we're removing them or changing positions because we don't want them to choke, right? What about if a patient vomits? What should we do? Should we turn them?
Yeah, we turn them to the side so that the vomit could drain out instead of going into their lungs.
Especially with those seizure patients too, because when they're having a seizure, we need to turn them to the side, even if they're not eating or not, because of the fact that they might choke on their own saliva. And as you mentioned, and some people are talking about the food, if they have dysphagia or a stroke, we want to have them do a swallow evaluation before we start anything with food or putting anything in their mouth with these patients. Okay. So the next thing we have is a pulmonary embolism. And pulmonary embolism means that we have a clot somewhere in the lungs. It could be a fat, air clot, blood clot, whatever it is. Then again, it's a respiratory. So dyspnea, anxiety, right? That feeling of impending doom. Why? Because if you have a clot in your lungs and it's blocking oxygenation and perfusion to the body, because the lungs and the heart are compatible in terms of anatomy, they're going to have that feeling of impending doom because they don't have enough oxygen. They're not taking that in, and that's going to make them feel a little woozy because they're having more CO2 levels. They also might have pleuritic pain, tachycardia, tachypnea, and decreased O2 sat. With all of these, we have a potential of a decreased O2 sat, especially when they're respiratory related. Now, more interventions, right? Elevating the head of the bed, oxygen 2 liters, altiplase, which is a thrombolytic, meaning it breaks the clot that's there. Heparin and warfarin are anticoagulants. They prevent new clots. They don't get rid of existing clots. And I know, if I'm not mistaken, there's really important times or things that we should look out for. What sorts of clotting times should we look at in terms of blood work for heparin and warfarin? There's some levels that we want to check.
Check the INR levels.
The PTT.
Yeah, I was about to say that.
Yeah, the PT, INR. What are those levels though? What should they be when they're on these drugs?
Was INR 2 to 3?
Yes. What about PT?
I think, was that like around 60 to 80?
Yes, you are on track. Yeah, so PT is 60 to 80 for heparin, and warfarin is 2 to 3. And the reason that is, these times are doubled or higher than the times they should be for a normal person. And this, I didn't know this, but I find it interesting and helped me understand why. And it's because if you have an increased clotting time, that means the time it takes for a clot to form is going to be longer. That's how it prevents a clot from forming. Whereas if it were normal, like in our normal clotting time, we would have that normal formation, but we want to prevent that normal formation of clots because of whatever sort of comorbidities that they might have. So we need the time to be increased. I hope that helps. I thought that was very interesting to understand why the times are that. But remember, NCLEX like safety. So what is the antidote for warfarin?
Is it vitamin K?
Is it vitamin K?
Yes, and what is vitamin K in?
What
Is
is
it
it
green
in?
leafy foods?
Yes, so we want to patient teaching. We
Oh,
don't want
okay.
them to eat too much green leafy foods. We want it to be,
Leafy
if anything, in
foods, yeah.
moderation. What about the antidote for heparin?
Protamine?
Yes, protamine sulfate. So those are just antidotes that we need to know, because as a nurse, that is a safety question. And the NCLEX, even if you get maybe 50% of the questions right, if you got 50% of or all the safety questions right, you are a safe nurse, right? You might not remember every symptom of every disease, but the NCLEX is looking for safety. So it is really good if you know, oh, I know my antidote. I know what to do in emergency situations. That's why I emphasize those respiratory drugs, because they're emergency-like situations, especially those reliever drugs. And yeah, as I said, we're looking at clots. So we're looking at those PT or the PTT, the INR, the platelets, hemoglobin, and hematocrit. Next we have pleural effusion, right? Which means that we have fluid accumulating in the pleural space, or the space that surrounds the lung. I like to think of it as like a pillowcase around the lung. So it cushions it and gives it protection. So, right, if I have fluid in my lungs, I expect to have crackles and tachypnea and decreased O2 sat. And what is that procedure that we do when someone has pleural effusion?
Thoracentesis
Yes, and what is thoracentesis?
is like aspirating, removing the fluid from the lungs.
Yes.
Procedure.
It's a little surgical procedure with the needle, and they remove, or as you said, aspirate that fluid. So we tell them, right, to lean forward. They shouldn't really talk, have their arms supported on a table, and they can pull out that fluid, right? We also want to make sure always that there's informed consent. They do not go right to any procedure if they don't have that informed consent. Now, do we obtain the informed consent?
No, the doctor.
No, only the doctor.
Exactly.
Or we
Whoever's
do
doing,
witness the signing.
yes, we witness. All we do is show that we were there, but NCLEX might say, oh, the surgeon went to go speak to a patient and did the informed consent, but then you weren't present. Then we don't sign that informed consent because we weren't there. So just little tidbits. Definitely comparing vital signs, and then from the baseline to how they were before, how they are now, and knowing how much fluid and what type, right? Like what sorts of drainage of fluid are we getting from that space and how much? It's good to know. The next thing we have is asthma, and asthma is an inflammatory chronic disease which causes bronchospasms and the airways to constrict and airway secretions. And the most common manifestation is wheezing, right? That's our little famous one for that. If you don't remember anything, I expect to hear wheezing in my asthmatic patients. They also might have tachypnea, tachycardia. They can also have anxiety. Why? Because they have decreased O2 saturation levels, which means they have less perfusion in the body, which can impact that feeling of anxiety, and they have more CO2, and that causes that feeling of anxiety in the body. Once again, interventions, elevating the head of the bed, oxygen, coughing, deep breathing, albuterol. And when should we hold albuterol? If we're going to give this medication, what should we be looking at in terms of vital signs?
Blood pressure.
Yes, but there's a more important one than that one.
Heart rate as well.
Heart rate, because we said that adverse effect is tachycardia. So if they have tachycardia already, we don't want to give them this medication. We want to hold it, because why would we want to make their heart rate higher than what it already is? And then, like I said, it depends on what it is, right? Albuterol is more of our short-acting reliever medication, and salmeterol or formoterol are our long-acting examples. So it depends what we're giving it for and why. Do we need immediate bronchodilation, or are we giving something to control? Those steroids we can give for inflammation, but we have to rinse the mouth, especially if it's in inhaler form, because of the ulcerations, that oral candiditis. Auscultating lungs, this is respiratory. All of these I'd want to auscultate lungs. If that was an option on my NCLEX, I'd pick it. Monitoring vital signs, that heart rate and the respiratory rate. and things like that. And remember, asthma is an inflammatory response. It could also caused by an allergy mediated response. It can have an allergy like asthma-like attack. So we want to identify triggers that can be causing that asthma attack and keep them away from them. So if they say that my kid's always in ragweeds and they're going to the hospital every week, maybe we shouldn't put them near ragweeds. Maybe that's causing an asthma flare-up. Any questions before I continue?
No, good.
Okay. So now we have COPD, right? And COPD is like kind of caused by different things. We know a big risk factor is being a history of a smoker, like a chronic smoker. And things could be emphysema, bronchitis, and that, or even cystic fibrosis can cause that. So some of these, like bronchitis and cystic fibrosis, we have those secretions. That's why anticholinergics a lot of times are used in our COPD patients to remove those secretions because they're anti-slud. And what are some manifestations, right? We said a key manifestation of asthma was wheezing, but what's some key manifestations in COPD, things that we expect to see?
Barrel chest.
Mm-hmm.
Maybe a bronchi.
Yeah, they can have crackles and things like that. And what else though?
Constant coughing.
What about the O2 sat? What do we expect level wise to be for them?
In the 80s.
Yeah, right. We're definitely not expecting 95 to 100. We're not going to call the doctor if we see 95. If they're in like the 85 range, it's okay. If they're getting like 80 and lower, then we're going to start worrying, right? But not as bad. Dyspnea, and they can also have respiratory acidosis. Why? Because these patients are having trouble breathing, and respiratory acidosis is when the pH is lower than 7.35. The normal range is 7.35 to 7.45, and the CO2 level is higher. I always remembered opposites. If there's a low pH in respiratory or a high pH, the other one's going to be different. So the CO2 is going to be greater than 45 because it's normally 35 to 45. That means that they have hypoventilation. They have poor breathing. So our COPD patients have trouble breathing. So they do have hypoventilation. So they're at high risk for developing respiratory acidosis as a manifestation. That's why those ABGs are really important to monitor for. What about interventions for COPD? We kept talking about a bunch of respiratory interventions. So what are some things, thinking about all the things we've talked about?
Chest PT.
Okay.
Elevate the head of the bed.
Okay, what else?
I do remember
Sorry, go ahead, Safi.
I do remember there was a specific drug they give in the diet for unless if I'm mistaken with cystic fibrosis. My bad. Never mind.
Yeah, you are thinking about that, but hey, at least you remembered that. That's props. What about does anybody else have anything to add? So elevating the head of the bed, chest PT, there's definitely a lot more that
I
we can
have
do.
one. Also, if the patient smokes, we could talk to the patient, find out like if they ever thought of quitting. And if they do, like we can suggest how do they call it again? Smoking, what's that word? Cessation? Whatever the word is.
Yeah, no, exactly, definitely. You want to talk to them about smoking cessation, and are you thinking about bupropion? Is that what you were thinking about? That drug for smoking cessation?
No, I wasn't thinking of the drug, to be honest.
Okay. Then never mind. But yeah, no, definitely smoking, because as we just said, that's a big risk factor for COPD. What else could we think about for these patients?
Assess if they have pursed lips when they're breathing.
We want them to do pursed lip breathing, because it's like like it's kind of like making the duck lips with your mouth because that helps with breathing for them. So we want to encourage pursed lip breathing, not as much the incentive spirometer with them. We want to do pursed lip breathing. We could also do deep breathing, assessing the lungs, suctioning as needed, but we could also give albuterol, but we have to once again hold if they have tachycardia. But what about oxygen? What's the problem with giving oxygen with these patients?
It's considered poison for them.
Yes, that's because they're used to having these high CO2 levels in that like respiratory acidotic state. So they're used to having more carbon levels than oxygen. So if I'm going to start giving them like an high flow nasal cannula of oxygen, this is not going to be good for them because they're used to being at a SpO2 of like 85. They're not used to being at 100. So that's going to have dramatic effects on their body. And that's why we have to be careful. We can give them oxygen, but nothing like a non-rebreather or something that gives a high flow because of the idea of oxygen toxicity with these patients. Okay, so the next thing we have is atelectasis, or the collapse of the alveoli, and the alveoli does gas exchange. So if that collapse, they're not going to have that perfusion in the lungs, and that's not good. They're not going to really be getting. So we have things like cyanosis and tachycardia and tachypnea and pleuritic pain because they're not getting that perfusion. They're not getting that. So it's going to cause pain in that area because they're not being highly perfused. And the cyanosis is a result of the lack of oxygenation going through the body because it's not proper gas exchange at the lungs. Now, interventions, elevate the head of the bed, right? Chest PT, suctioning, cough, deep breathing, incentive spirometer, ambulation, turning them to help with secretions. All these interventions just keep repeating. So like if you were studying for the NCLEX, what I would do is just make a list of respiratory interventions that you could do. And then as I'm looking through the diseases, think about which interventions I would not do, right? Such as maybe giving high flow oxygen to someone with COPD, or maybe using pursed lip instead of incentive spirometer. But regardless, everything else is the same: elevating the head of the bed, chest PT, suctioning, deep breathing. I mean, you have like lots of them, assessing the lungs, things like that. The last two things we're going to talk about is epitax. I can't say that one, so you know what I mean. And the high pressure and low pressure alarms. So what does epitaxis mean?
Nosebleeds.
Okay. And what sorts of interventions should I do if somebody has a nosebleed?
Pinch the nose, lean forward and hold for 5-10 minutes to stop the bleeding.
Okay. What else? Should I put things in this patient's nose if they're bleeding?
No, I don't think so.
I
What
thought
about
You
put
have to
gauze.
avoid anything that causes nasal trauma, like picking at their nose or like blowing forcefully or spicy foods or like really high exercise.
Yeah, because right, we don't want to put anything in their nose. I know they did. I think there's something that Habib might have said about maybe I think putting a balloon or something if it's that bad, but we don't want to put anything in their nose normally, especially if they're bleeding. No, you said no vigorous sports, no big nose blowing, no suctioning of the nose, especially because it can, as you said, it can cause more trauma. It can cause the nose to bleed more, and we could also humidify the nose to help with that bleeding. Now, is there any questions before we get into the difference between high pressure and low pressure alarms for the ventilator? No. Okay. So what's the difference before we even get into the symptoms? What lets me know that I know I should know it's a low pressure versus a high? In other words, is which one is something wrong with the patient and which one means there's something wrong with the machine?
Is it a noise it's gonna make?
Say that again?
Is it a noise?
Yeah, well, the high pressure alarm and low pressure alarm both make different noises, but one alarm means this is affecting the patient. The patient's having a problem, and the other one means, hey, there's something wrong with the machine. So which one is which?
High pressure would affect, it's affecting the patient, and low pressure is because of the machine.
Yes. Mm-hmm. So if low pressure means there's something wrong with the machine, there's something wrong with the ventilator, what do we do? What are some things that might mean?
And that it's kinked?
Kinked is more high pressure. What about dislodgement of the tube? Could that be a low pressure?
Yes. Checking if there's any leakage in the cough section. And disconnect the tube.
Mm-hmm. So dislodgement, leakage.
I have a question.
Yeah.
Are you asking about the the patient or the machine?
So my question was, I guess it was confusing, is the low pressure and high pressure alarm go off for different reasons. So I was asking which one means that the patient is the cause for the alarm to go off, and which one means that it's a machine. So low pressure means the machine is going off because there's a dislodgement or a leakage or a disconnection. Whereas if I see high pressure alarm, that means something is going on with my patient.
So why wouldn't kink be the machine?
That I don't even know. Honestly, I don't know what kink means. Does anyone know what that means?
Okay, it's like it's bent. You know, like a hose. If you turn the water on, and the water is running through the hose. If you hold the hose and you bend it, that water is not gonna continue, right? It's gonna backflow. So it's like bending a straw. So that's kinked. Kind of like that's the best way I can explain it.
I guess it's from them. I guess that's why they put biting slash kink. I guess the kink is in
Yeah,
as
kink.
a.
Yeah. Mm-hmm.
I think that's why they mean it's patient related because they are
Mm.
causing or the reason
Mm.
of the high pressure to go off.
Okay. All right. Thank you.
Okay. So high pressure, as I said, that means the patient. So they might need to be suctioned. They might have so many secretions that pressure can't get in. So it's building up and causing the high pressure, or they might bite it or kink the tube or bend it, now that I know what that means, where it's causing that high pressure buildup. They might have bronchospasms, so that constriction causing that airflow that's going in to have that pressure, so it's going to also make the high pressure alarm go off. Or pulmonary edema, right? Another way of saying the lungs are swelling and that is causing the high pressure alarm to go off. So I always think high pressure means something to do with my patient. So they might need to be suctioned, they might have an airway, something obstructing their airway, they might be biting the tube. Whereas with low pressure, I'm thinking about there's something going on with the ventilator. So maybe it's dislodged, maybe there's a leak, maybe there's a disconnection. But regardless of which alarm's going off, what do we do when we hear an alarm go off?
First thing is to check the patient.
Yes, because even though low pressure means machine, we always go to our patient first because don't forget, these are machines and they can go off for the wrong reason. But we need to always assess our patient first, make sure they're breathing, make sure they're okay, see how those vitals are, and then we can figure out why the button is going off and call respiratory. Okay. I don't think there's anything else that's needed to go over. Is there anything else that you want to go over? Or we could save it for next week? Like that. I'm gonna stop the recording. Give me 1 second. Stop.